Lovely. And I'm going to pass over to Gerassimos. Over to you.
Thank you, Bavina. Good evening, everyone. I'll just share my screen. I hope you can see my screen.
Yes, we can. We're still looking at perfect.
Great. So yeah, so I've put together a few slides about the kind of information that you may want to include in your glaucoma referral, or things you may want to ask about or think about when you refer someone into the glaucoma service. So let's start with the presenting complaint. It may just be a routine eye test. The patient may not have any symptoms, and you may find something in the optic disc that makes you think that the patient has, let's say, glaucoma. Or the patient may have halos. I've put here some symptoms suggestive of intermittent angle closure, especially at night. When the pupil dilates, they can get intermittent angle closure and experience halos. I've put here glare or blurred vision. That is more typical of cataract, and it's important to differentiate symptoms that may be relevant to glaucoma from symptoms that may be caused by cataracts. Unless they have advanced glaucoma or paracentral field loss, you wouldn't expect a patient with glaucoma to present with blurred vision. Migraines and Raynaud's, so poor blood flow, blue fingers when it's cold. These are typical of normal tension glaucoma. So you may want to ask about these things if you suspect someone has normal tension glaucoma, and include this information in the referral. Other relevant pathologies to normal tension glaucoma are chronic anemia, systemic hypotension, and history of severe blood loss, needing, let's say, transfusion because someone had an injury, a road traffic accident. Then other relevant symptoms would be symptoms of acute angle closure, such as nausea, vomiting, red painful eye with loss of sight. And again, in terms of symptoms, if the patient is already on glaucoma drops, they may experience, let's say, complain of bitter taste with the carbonic anhydrase inhibitors, or dry mouth, nose with the alpha-2 agonists like alpha-GAN and diopidine. In terms of the past ocular history, it's useful to know whether the patient is myopic or hypermetropic. Obviously, hypermetropic patients are more likely to have angle closure disease, and myopia is a risk factor for primary open-angle glaucoma. History of laser refractive surgery, that's relevant in terms of the corneal thickness. These patients tend to have thin corneas, and so we are underestimating their true eye pressures. And they often have pressures of 15, but if they've got very thin corneas, it may in fact be a lot higher than that, the pressure. It's also relevant to know whether they're pseudophakic or phakic. Pseudophakic patients are less likely to have develop angle closure disease, and phakic patients, especially if they've got a cataract, you need to think about phacomorphic glaucoma, think whether the lens is cloudy and pushing the iris forward and causing secondary angle closure. The ocular surface is also relevant in terms of deciding whether a patient would be more suitable, for example, for SLT or for eye drops. Obviously, with SLT, it's less likely to aggravate the ocular surface long-term as compared to taking drops for life. Trauma, if there is history of trauma, you may want to think about angular recession, and obviously you would need gonioscopy to identify this. But in the context, let's say, of someone who's got very asymmetrical pressures, it's one of the things to consider. So if one eye is 15 and the other 30, trauma is a possibility in angular recession being responsible for the high pressure. And then causes of secondary glaucoma, such as uveitis, previous VR or other eye surgery, and proliferative diabetic retinopathy. And I've put there all the scars. I had a patient with a nasal field defect that I couldn't explain from the appearance of the optic disc. And they were on dilated fundoscopy. I found them to have a big toxo scar in the temporal retina. Now, in terms of past medical history, obviously we want to know if the patient suffers from asthma or COPD, and we know that we avoid beta blockers in these patients. If we have to use beta blockers, we used to use betaxolol, which is more cardioselective and causes less respiratory symptoms. Or we can use Thiopex, which is a low concentration beta blocker once a day with punctal occlusion. If they've got bradycardia, that's another contraindication for beta blockers. Arthritis, that's relevant when the patient it's useful to know if the patient is going to be able to take drops and use them themselves, squeeze the bottle and apply the drops regularly. Wheelchair, mobility issues. I've put there virtual clinics because sometimes these patients come to the virtual clinics and they're not very good candidates for these clinics. Dementia and other neurological conditions, they can affect visual field performance. They can cause visual field defects that may mimic glaucomatous field defects. So it's important to know these things to make more sense of the visual fields. Social support, again, in terms of drop installation and being able to attend follow-up appointments regularly, it's useful to know the social background of the patient and their occupation, which will determine their visual requirements. We would again obviously ask about whether they drive or not, the ethnicity. We know that Asians are more likely to have primary angle closure glaucoma, and Afro-Caribbean patients develop more primary open-angle glaucoma, and it tends to be more advanced and more aggressive in general as compared to the Caucasian patients. And of course, family history, especially in first-degree relatives. Again, as part of the referral, we want to know about the medications the patient is taking, if they are on tablets for their heart or their lungs. If they take beta blockers, they should be taking them in the morning, not at night, because at night it can reduce the blood flow and reduce the perfusion of the optic nerve. If they are on blood pressure, diabetes and cholesterol tablets, that's useful in terms of the cardiovascular background of the patient, which is again relevant to the ocular blood flow, but also things like pseudoexfoliation glaucoma are known to, these patients are known to have more vascular problems. Use of steroids, either at present or recently. Antiepileptics, like topiramate, they cause cilio-choroidal effusion and they can push the iris lens diaphragm forward and cause secondary angle closure. Antidepressants, SSRIs like sertraline, and other antidepressants like amitriptyline and citalopram, they have an anticholinergic effect and can cause dilation of the pupil and angle closure. Similarly, antipsychotics and benzodiazepines have a weaker anticholinergic effect. Cocaine can also cause dilation, and medications for Parkinson's disease can cause secondary angle closure. In terms of the examination, it's important to know the visual acuity of the patient. That will determine also, in some cases, the type of management they should have for their glaucoma. For example, patients with poor vision, typically hand movements are worse, they may have diode as opposed to filtration glaucoma procedure. If you have Goldman, it's useful to check the pressure with Goldman. We discussed documenting the presence or absence and the density of any cataract the patient has. Panheric, but if you have experience with gonioscopy, it's even better to provide gonioscopy findings. The anterior chamber depth, and if there's any activities or uveitis that could cause secondary intraocular pressure spike. Dilated fundoscopy. So ideally, we want to examine the disc with the patient dilated. It's not always practical, but it makes a huge difference, especially if the patient has a bit of cataract, in terms of assessing the appearance of the disc, the presence of disc hemorrhages, identifying nerve fiber layer defects. We want to look for pseudoexfoliation and pigment dispersion. You can see the pseudoexfoliation material on the lens often, and usually they're much easier to see when the patient again is dilated. Transilluminate the iris to look for iris transillumination for both of these conditions. Look for iris new vessels in the context of a diabetic patient with very high pressure. Maybe they've got rubiosis. Look for, if you do gonioscopy, you can look for new vessels in the angle. And if you dilate the patient, you can look for new vessels at the disc or in the periphery of the retina. It's also very important to document the color vision, especially in patients with normal tension glaucoma, or where the disc, so normal tension glaucoma in the sense that the pressure might be 12, but you might be thinking that this patient has a field defect and they may have glaucoma, but the disc also looks a little bit pale, so you're not sure if it's another optic neuropathy. Always do color vision. Silicone oil, something you can see in the anterior chamber. If you look carefully, you can sometimes see little bubbles of silicone oil floating in the AC. If you do gonioscopy, it's even more impressive. You can see the oil in the superior angle. And the presence or absence of RAPD. In advanced glaucoma, you may see an RAPD, and it's a good prognostic finding. Then I've got diagnostics here. Obviously, if you have 24-2 visual fields, that's very important. We've already mentioned corneal thickness. And I've also put here disc and macular OCT. It's not necessary as part of the referral into the glaucoma service to have a disc and macula OCT. But if you've got it and you know how to interpret it, then it's a useful information. It might help you to confirm your diagnosis. When I say macula OCT, we are more interested in the ganglion cell layer. If you know how to use the ganglion cell layer findings on the macula OCT, that's really useful. And finally, yes, so obviously, if you could document in the referral letter what you've told the patient and what your plan is, how soon you would like them to be referred and into which service. That's all I've got. I think Ms. Sobi has a slide about angle closure, and I'm happy to discuss anything you would like on these slides.
Gerassimos, if you're okay to stop sharing.
Yes.
And then Miss Obi can then share hers. Thank you. Thank you for your teaching today, by the way. Miss Obi, you're on mute at the moment.
Thank you. Thanks for reminding me.
Okay.
Let me open it first. Bear with me. And then hopefully I can share it now. Find it. Okay.
Thank you.
Okay, so can you see it all now?
Yes, we can.
Okay, fine. So it's just one slide, basically. So I was at the College of Ophthalmology last week up in Glasgow, and we had Prof. Foster talking about the angle closure guidelines, which have been in the pipeline for the last 2 years, but held up a bit because of COVID. So he's really very keen that, to share this message with optometrists, because the move is to get people to refer only angle closure disease that is likely to require intervention, because we're moving away from intervention, accepting those who are most at risk, because of all the recent studies that have shown that actually the risk is not very high for the vast majority of the population. So what you'll hear people talking about now is primary angle closure disease plus or minus, okay? So PAC plus disease is where you have your typical narrow Van Herrick, so your peripheral limbal chamber depth of 25%, less than 25%, okay? So you're either looking for that, or if you're in one of those big screening clinics, which we're hoping to set up, for example, in Artesian, in King's Health Partners in the near future, you might be doing an anterior segment OCT, which will show iridotubercular contact, okay? Above the level of the scleral spur. So that's something to think about as well, okay? Now, what makes it PAC plus disease is having a narrow Van Herrick, all right, with something else, so at least one of the following. So they might have just something that increases their personal risk, okay? Or in a person where you really don't think they can report symptoms well, okay? So if they've only got one good eye, obviously you're not going to take any risks, so you're going to refer. If they're vulnerable, so that is people with learning difficulties, dementia and so on, who are not going to maybe notice when things are progressing, or know how to get in touch with an optometrist or any healthcare practitioner to if they have any concerns. Obviously that might be someone you'd want to refer. If they have a family history of significant angle closure disease, so that's typically particularly a maternal history, or siblings who've had acute angle closure, for example, or have needed intervention for angle closure with laser or cataract surgery, then that would be significant. And so any of the plus things that you have, do make sure you include it in your referral. If they're known high hypermetropes, so above +6, then that's relevant. if they have diabetes or they have some kind of ocular disease that means they need frequent pupil dilatation. So for example, people on hydroxychloroquine screening, for example, or with sickle cell disease or any other macular degeneration, all those people having regular screening. Can I just ask you to mute yourself, please? Sorry, if you're not speaking. Yeah. So if they're on antidepressants, Gerassimos has already touched on this, or they're anticholinergics, the things like the bladder medications, those can actually narrow the angle, so that would be considered an extra risk factor. If they're living in remote locations, so they can't get to the health service, if they do develop any symptoms, then that might be a problem. So, for example, one of mine was a reverend on a submarine. Okay, these are people that travel, or they're all over the place, traveling frequently. They may not be able to get to any health care, the hospitalized service when they need it. And what they're also trying to do is to bring angle closure referrals in line with open angle referrals. So the idea is to move towards referring people really only when they have these plus disease, or if they have an intraocular pressure of 24 or greater measured with Goldman tonometry. So basically the take-home message is avoid referring what we consider PAC minus, so that's angle closure features without any plus disease. So if they have just a narrow angle seen on Van Herrick, then they can be monitored with an optometrist. Okay, so I don't actually know when these guidelines will come out from the College of Ophthalmology, but I think there's just some final I's to dot and T's to cross, and then hopefully it'll all be available, and your college will be sharing them with you.
The guidelines are already available and downloadable from the website. So it's a beautiful document. It's about 20 pages long. And these ones are shown in little square boxes of the take-home messages. So it's worth downloading it, or we can circulate it. I can probably send a copy of the last version. I'm sure the finalized one will be updated as they get them.
Yeah, they just want to try and finalize a few things. Thanks, Sansi. And so I know your College of Optometry usually sort of tweaks things a little bit, bits that they want from you as well.
Yes, they have. So for anyone who is a college member, College of Optometry member, I should stress, college ran a training session, a webinar, the tail end of last year, that discussed angle closure glaucoma and PAX plus and PAX minus. So if you are able to log on to the college, you can watch that webinar and see what was said at that point from an optometrist point of view. Right.
Just one more thing I was going to say, sorry. And I mean, Gerassimos did touch on it. And please, if anybody has any questions about your referrals or things, or any feedback for your referrals, now's the time to discuss it. But what's really helpful is if there's anything that doesn't quite meet those criteria, but there's something that concerns you about the patient, say you've been monitoring them and there's a sudden change, or is there asymmetry that you're suddenly worried about, or something else, just make sure that that comes across in your referral as well. Okay, so sometimes they are some soft things, but if you actually verbalize those and write them down, then that might sway us to actually consider seeing the patient where we might have just rejected the referral otherwise.
So thank you very much for the glaucoma teaching today. I'm just going to stop recording